Yes, absolutely. It integrates really well. It's not more work at all. I think it's, if anything, it's less work because you're not having to wait for results. You're not having to chase results up. You know when they're coming. If you've told a patient to do the test, then most of the time they'll do the test. And we have been quite open with patients about the cost of the test and the importance of them doing them now, especially with those few that did go out of date. So now our conversation is, I kind of do this. This is a really good thing. It's great. I want to give it to you, but it's £30. And if you waste that, then, you know, that's gone. And that's £30 that we can't have in the kitty for either yourself or somebody else. So, and actually people respond to that reasonably well. And I think we do have to think about the cost of healthcare as patients, as people, as, you know, as health. Oh, absolutely. It's sad, but you do have to think about it. So we do have some patients. We always have some patients. And I'd love to know, I don't think anyone's ever answered the question about why people don't do things that are going to help them. It's like self-sabotage or something. And there's a whole, especially with the digital tools that are coming our way, there's probably a big research study there for us to look into, seeing why people don't take part in these preventative health activities that, yeah, I don't know the answer to that one. But no, I would say it's not any more work. I think it's manageable. It's no more work than filling out forms and writing on a stool pot to send off to a lab. When you're setting somebody up on the system, it takes no longer than that. In fact, I think because we're so quick at it now, because we've been using it a while, it's even quicker. I'm still thinking about writing on the little pots and getting your writing small enough, and yeah, making sure you've spelt the name right so it doesn't get rejected, and all the other things that can happen. I think it depends on the patient. I mean, some patients would need more support than others, but you know, I think it's probably about 10-15 minutes to go through it in its entirety. But also then backed up with the online resources and the YouTube video showing how it's done. Many people like the fact that the app's actually got the step-by-step instructions, so they can't really go wrong with that. So yeah, it varies. I think the longest I've had to spend is about 45 minutes, but that was, you know, actually was worth it because the patient is still using the test. So yeah, individualised attention. It doesn't matter with inflammatory bowel disease patients. There is such a variety of individuals. Well, human beings, we're all individual. We all need different attention. And I think it's remembering that you can't get a one-size-fits-all approach in healthcare in anything. If we could, everything would be easy, because it would be easy and manageable and measurable, and everyone would get their 10 minutes and move on, so the next person could come in on time. But you just have to manage that appropriately. Now, do we have the time? I don't want to lie and say we do, because sometimes it does put pressure on clinics, but it's worth it. Like I say, in the long run, it saves you time, and in the long run, it's better for the patient. You know, I think in the future, these kinds of tests will become just routine practice. We won't be thinking about them as something novel and new. We'll be thinking about them in terms of the patients that we'll go back to those that aren't using it. We'll be asking why they're not, and perhaps focusing more attention on those rather than on the people that are using them. If a patient requires the attention, so you as an IBD nurse, you get to know your patients well, so you know the patients that need a lot of contact, either by telephone, email, or whatever it is they need. So they may well need that phone call just to say that's green, it's brilliant, it's absolutely normal, go about your daily business. Other people would say, if it's green, we're not going to contact you because that's good news. If it's amber, then it may be just hold fire, we're not going to be doing anything, but we'll let you know what it is we're going to do, whether it's monitor you more closely, do another test in, 3 months' time, whatever it is we're going to do. If it's red, then we will be in touch, and that's the general rule. That's what we tell them at the point we sign them up to the test. And that's true for even those patients where they had a high result, but actually didn't have active IBD. It was still important to do something for them, because there was still there was a reason why we did the test in the first place, because they presented with symptoms, and two, because if you didn't do something, and actually if we didn't follow that up, say with the flexible sigmoidoscopy to rule out inflammatory bowel disease, then you could end up with a disaster on your hand. So doing something is important. And I think the other time to think about these things is when you get a normal result, but the patient's still got symptoms. That's a variance. We wouldn't ignore that. If a patient's told me they've got quite severe symptoms and a normal result, we'd still be looking to try and help them with those symptoms, even if they're not inflammatory. It may be that we're repeating the test because perhaps perhaps the sample they used was a diluted sample, or perhaps it would be about going for a colonoscopy just to have a look. But we didn't have any incidences where there was a normal result and an active disease. So that's really encouraging. And it may be because I'm a nurse and I'm not so worried about the minutiae of the numbers. I am using the traffic light system has been really good. In fact, it's starting to influence our practice in other ways as well. So when we were categorising on the poster, we were categorising the colonoscopies to fit with the normal amber severe results. Actually you can do it the same way with a colonoscopy. You can have a normal, it's green, you can have an amber, it's moderate, or it's a severe colonoscopy. So really, and with all these digital tools and the development of them, having heat maps and it's all going to be so much more possible just by integrating these results along the way. So the consultants are all signed. They've all signed up to the fact that we're using the kit. So we haven't talked about that in the poster this time, but we do use it in a slightly different way as well to try and help speed results for inpatients, for example. We will get the patients to gather a sample using the Calex device, and then we'll do the second bit ourselves and get the result for them. And the doctors really like that they can have a patient that's perhaps in ED, do they want to admit them? We can do a test, we can do that quickly, they can get a very immediate result and know what they're going to do, whether they're going to send the patient home or admit them. So again, quicker than a flexible sigmoidoscopy is going to be, even though we do manage to get those in within the requisite time for an inpatient. So that's helpful. And our digital system that we use, at the moment it's not integrated with the portal, with the IBDoc portal. But what we do, so we transfer the result into that system and then that comes up on a graph. And so the consultant sees the patient in clinic. They've got their calprotectin on one side, and on the other side you've got the patient reported outcome measures and the disease activity scores, so they can instantly see what's going on. If they've got a normal result with symptoms off the chart, then again they'd make the same decision about repeating a test or going to flexible sigmoidoscopy. I mean, sometimes, in our inflammatory bowel disease nurse led unit, we are very autonomous. So I work at an advanced clinical practitioner level. I've done a master's degree with advanced history taking, physical examination, prescribing. So there's many decisions that are made in our team that don't have to be discussed in a more MDT environment. However, there are always those patients that are more complex that we share, that we discuss, and we would do that. It's really quite empowering for nurses in the UK that we've got this model now where actually the medical team trust us enough to be making clinical decisions at a very complex level. We're seeing new patients it's incredible. And I think tests like this actually help us. They help support that decision making and help the doctors to feel more confident as well that we're doing the right thing for the patients. And that's another thing that we're hoping that IBDoc will support us with is what I'm sort of calling a triad of care, shared care. We've got the patient at the point, we've got what we call secondary care at the moment, and primary care, and that we can all talk together using these digital tools to evaluate the results, and truly shared care, like I say, with the patient at the heart of it all. Not really, to be honest. I think the only trend probably is those patients that are maybe nervous, maybe worried about their condition. There's that trend. The other trend is there's those patients that are complex, that perhaps we're trying novel therapies on, different combinations of treatments, and we want to see what the results are closely, or we're worried about them in terms of, if we leave them for too long, is there a chance that they'll perforate the bowel, and all the other things you worry about. But age, we live in a very demographically diverse area, let's put it that way, but mainly lots of people come down to retire. So over 50 is the biggest chunk of our population. And yeah, I think I've got an 80-year-old signed up on it, so I don't think there's been any difference in willingness to take it on, other than whether they've got the right phone or technology available. So no, I think and I think that'll change over time as well. I think it'll just become, like I say, part of routine practice to use these digital tools to help look after yourself. I think so. There's the group of patients where there's patients where that they've probably, I suppose there's some selection bias here, because you think about the patient that is going to be best suited to supported self-management. There's that group, and they're probably the patients, the 41 patients that were really well, that actually had no treatment changed. They're the patients that we thought, right, we get those signed up because they're the most likely candidates to be the first ones to take that sort of system up. But then there's the other group of patients, and those are the more complex patients. They're the ones that we really want to keep a close eye on. So the value of it is very diverse in that effect. It's valuable for the well patient to know they're well, to go about their business knowing that they don't have to come into the hospital, but it's also valuable to the clinician and the unwell patient to keep a close eye on what's going on, to check to see if treatments are effective. Patients have a lot of anxiety about their disease when it's active, and they also have a lot of anxiety when they're having to cycle through treatments, which is our current state of affairs. We don't know what's going to work for the individual at this point. We're hoping in the future that personalised medicine in IBD will actually be a reality with biologics, and knowing that anti-TNF isn't going to work, that would be great. So move on straight to something else. So, and I think this will play a part in that kind of therapeutic drug monitoring that as we go forward. That group of patients they're going to be the group of patients that I target when our integrated portal becomes available. They're going to be the first group of patients to get signed up to this, because one, they're already engaged with digital technology, because we're using a supported self-management tool for them already, and two, they're well, so it's low risk. So it just means then that what we would want to do is review them using all of those tools, the caloprotectin, maybe a blood test, maybe the patient-reported outcome measures, the disease activity scores. And then if all's well, then we would defer their appointment for a year. So these are patients that would usually be seen on an annual review. And it's nice to have a chat, but usually that's what it actually entails, is they come in, they're fine, and it's nice to see them. But who knows, we may even be using digital technology, video technology to talk to them at home, if they still want that feeling of a face-to-face conversation. We're using that within the trust already on a trial basis, so there's no reason why we can't integrate that into any digital tool that we've got. And if it's available in the trust, then that will be an easy thing. So, yeah. In fact, it would be really good. The patient might not have to leave their home. Who knows in the future? I might not have to leave home. Even better. Can do it all from home. Yeah.